Hi guys, good evening and greetings everyone. I think people can see me, hear me. If you can do, can you give a thumbs up? Maybe, yeah, I think we are back online. So today I'm back with a case. Hi, Pradanya. Good evening. And Sunil Gupta, good evening. And Mahesh, hi, good evening. Yep. So today I'm back with a case. So I'm discussing a recent case. I mean, not very recent to be honest. This was a case that happened couple of weeks, maybe 3 weeks back. So this was the case here. So I don't know why I couldn't see what's happening here. Okay, all well, all set. Couldn't check in the YouTube, by the way. Yep, now it's fine. Okay, so the case for today is 32-year-old gentleman, COVID 19 positive. I mean, that was the trend right now. Developed cytokine storm with 90% lung involvement and score 21, which means it's moderate to severe, so that's what it means. Record with targeted therapy, developed fever, once again by day 14 and increasing leukocytosis. CT is shown. I'll show you the CT. So how will you proceed? So that's what the question for today is. And I have implied the term cytokine storm here in this particular case, and after that I have mentioned something on targeted therapy. So everyone should be aware of that. So suppose whenever the patient is having a cytokine storm, what are the therapies that you generally prefer? So I mean, with the trends of going with COVID-19, I'm not talking about the antiviral drugs. There are a lot of antiviral drugs that have been, I mean, probably getting approved, but I don't think what is the efficacy of this antiviral drugs to be frank. So hi Murtaza, good evening. Yeah, tocilizumab is what we tried with this guy. So what we are on the trial phase. And in our hospital, we are doing a trial on double dose tocilizumab, double dose standard weight based tocilizumab. Yeah, so this is what the trial we are on right now. So we are doing in our hospital right now. Day 14 is, I mean, D14 means day 14, 14th day of illness. That's what I mean, day 14. Anyways, double dose tocilizumab. Usual dose of tocilizumab recommended by Government of India guidelines is approximately 400 milligram 2 times a day. So 12 hours apart, 2 doses. So this is what the tocilizumab dose, but we are actually on a trial phase, giving standard dose tocilizumab, weight-based tocilizumab, that is approximately 8 mg per kg, weight-based tocilizumab, and we are giving 4 doses, not 2 doses, 12 hours apart. So this is what the trial we are doing right now. So whether the patients are doing well or not, especially in patients who are having a CT score which is very severe, and anyone who's having more than 80 to 85% lung involvement, we are planning to give 8 milligram per kilogram full dose, that is 4 doses of tocilizumab 12 hours apart. And the maximum dose we have set is 800 milligram. That is what we call double dose tocilizumab, and not 400 milligram as recommended by the Government of India. So this is what the trial we are doing right now, and we are getting good benefits, but still the results have to be consolidated, and we have to do it after some time. So it will not be available in the next 2 to 3 months. Anyways, fine. So this was the patient, and he was having fever once again. Initially, he had a very good resolution of the fever. This patient, to be honest, we started on azithromycin. He He didn't get HCQ though. HCQ we stopped giving in our practice, so we are not using HCQ. But he was getting azithromycin, and he was getting lopinavir ritonavir combination. At the same time, he was getting methylprednisolone. So standard dose what we use right now is 80 milligram IV once a day, and he got the methylprednisolone dose for 7 days. So usually the guidelines say you can give it for 5 to 10 days. That's what the guidelines say. So in moderate cases we stick on to 5 days. In some moderately severe or severe cases we go up to 7 to 10 days. So anyways, fine. So 7 days we gave methylprednisolone for this guy. Why HCQ we stopped in this guy? Because we personally felt no evidence for HCQ. That is the reason why we stopped HCQ in our hospital. So not because of side effect. So we felt there was no evidence. Anyway, there are no concrete standardized trials to tell that HCQ is beneficial. For that matters, even azithromycin is highly questionable whether to give it or not. But why we do give azithromycin in our hospital setting is because there is some rationale behind that, because it is something that can cover atypical pneumonia also. It can cover certain organisms of atypical pneumonia also. So that is the reason why we still stick on to azithromycin. So because of the slightest possibility of someone having an atypical pneumonia. So that is the reason. Apart from that, there is no evidence as far as COVID is concerned with regards to macrolides and atypical pneumonia, even though a lot of articles are there, but still we don't have enough evidence for that. So the same reason. So that is the reason we still stick on to azithromycin, nothing else. Anyways, methylprednisolone we tried for 7 days, and as usual, as I told you, we gave this tocilizumab for 4 doses in this guy. This guy weighed around 90 kilograms, so we gave around 650 milligram of tocilizumab. 4 doses of tocilizumab is what we tried. Anyways, fine. So this was the regimen he got, and all the medications was stopped. He got better. When he came into the ICU, he was having a saturation of only 89-90%, but luckily he was not intubated, and he was maintaining a good amount of oxygen saturation with NIV itself, and with a little bit of support. So he got a good saturation, and somehow he recovered. It was around day 10 he started recovering, and by day 5 onwards he didn't have any fever, and by day 14 he started developing fever again. Started recovering. SpO2 was 94%, but with 20 mask of 60%. 20 of 60 was maintaining SpO2 of 90, and we weaned off NIV. So there's no NIV anymore from day 10 onwards. NIV is non-invasive ventilation, for that matters. I don't know how many pre-final or final year students are here, and anyways, so if you are any pre-final or final year students here, it's a little bit tough. So I'm talking about non-invasive ventilation here. So non-invasive ventilation in our setting, we generally try BiPAP, that is bi-level positive airway pressure. That's what we tried. Anyways, by day 10, his saturation was 94%, and we with a venti mask of 60% oxygen. You know what is the color coding for 60% venti? It is green color. So different color coding is there for venti mask, the Venturi masks. So green color is what he's getting, which means green is generally a sign of high flow high FaO2. It's 60%. That's what he's getting, and he was completely weaned off NIV, and he was only on venti mask oxygen. He was very much better by day 10. By day 14, he developed fever again, and he started developing increasing counts, leukocytosis. It was the reverse of what we saw, because in the beginning of COVID, his total count was low. Platelet was borderline in the range of 130,000 to 140,000, and his lymphocyte count was very, very low. Absolute lymphocyte was actually around 500 to 600 for this guy. That itself is a marker of severity. So as far as our hospital is concerned, we generally try to one second. So this thing often happens with this. Yeah, sorry. Sorry for that. So usually in our hospital, we keep a simple scoring system. We used to measure the ferritin levels. We used to measure LDH. We used to measure CRP. We used to measure interleukin 6 levels only at the first visit. Maybe later on when he gets sick, we'll do the repeat interleukin again. We do CT chest for moderate to severe cases. For any patient who's having low saturation, we do a CT. Otherwise, we do a chest X-ray at least minimum for all mild cases, to be frank. So these are the basic protocol we generally tend to do. But this guy has a very high LDH, and we also do the absolute lymphocyte count and the absolute neutrophil count, and we see the ANC-LC ratio, that is called a neutrophil lymphocyte ratio. Whenever the NLR ratio is more than 3.1, that is actually a marker of severity, and these patients tend to do a little bit bad compared to all the other patients. And whenever LDH levels are more than 500, obviously it tells you the disease burden is too much, and that's why we predict severity by LDH more than 500. But on the other side, ferritin, CRP, they usually do not predict that much of severity. Some patients who are having very mild disease also may have a very much significantly elevated ferritin and CRP. But one thing that ferritin and CRP correlates is the fever. So the duration of fever is highly correlating with the ferritin and CRP. That's what our trial results are there in our hospital. And IL-6 levels, yes, they do correlate. Less than 100, unpredictable. They can be in the range of mild to moderate. Usually they don't progress to severe cases. Anything in the range of 100 to 800 tend to be moderately severe. Either they will be moderate or severe. Anything more than 800 they tend to be severe. So this is what we have been predicting till now, so for in our setting. So anyways, all these results need a long way to go, but this is what we have been predicting in Chennai as far as in 2-3 institutions combined as of now. Anyways, this might be useful for people who are doing COVID duties right now. But anyways, so what is the reason for this increased total count, and how will you approach this increased total count? And he's having a new fever. So what is the differential diagnosis, and how will you approach from here on? So anyone? I'll show the CT after some time, but I need to know the differential diagnosis. So somebody can tell the differential diagnosis, I can wait for them. No one. Okay, whenever this kind of cases, the differential diagnosis, I think, yeah, secondary bacterial infection, yes, but this kind of cases, the first thing I can think about is steroid-induced increase in total count. This might happen, but this does not explain the fever. The patient ideally should not have a fever in this setting. So the glucocorticoids itself can cause fever, increased total count, because that's very quite common. You know very well that almost 50% of the neutrophils are generally marginated neutrophils. 50%. This is a fairly straightforward thing. They are marginated neutrophils, and only remaining 50% are in the circulating pool. 50% are in the circulating pool. But whenever you give a glucocorticoid, like for example any glucocorticoid for that matters, including your methylprednisolone or probably dexamethasone, doesn't matter. Any powerful glucocorticoid you're going to give, they're going to demarginate these neutrophils, which means they're not going to stop anything. So they're just going to demarginate this marginated neutrophils. So glucocorticoids will result in demargination. So once they're going to demarginate these neutrophils that are marginated will start entering the circulating pool. And because they start entering the circulating pool increases apparently. It's not a true increase in count. Apparently the circulating pool starts increasing, and that is the reason it will manifest as a high total count, and that is not something to be worried of. You can test this when you are in a clinical practice. Okay, Dr. Happiness is asking methylprednisolone is good or dexamethasone is good. There is one UK trial that is telling dexamethasone is good, but I prefer methylprednisolone till now because of the superior lung penetration by methylprednisolone. For lung levels, methylprednisolone is good, so that is why we prefer giving a methylprednisolone. But anyways, both are glucocorticoids and both are good. I don't think there should be any difference between these glucocorticoids. But there are some activity-related differences. For example, if you take a basic glucocorticoid, that is hydrocortisone, which is having a glucocorticoid activity and a melanocorticoid activity of 1:1 ratio. If you take a prednisolone, it has a glucocorticoid activity of approximately 4 and melanocorticoid activity of approximately 0.8. And if you take a methylprednisolone, it has a glucocorticoid activity of 5 compared to that of hydrocortisone and a melanocorticoid activity of 0.5. And if you take dexamethasone, it has a glucocorticoid activity of approximately 20 to 30, which means 5 to 7 times more glucocorticoid activity compared to prednisolone itself. And at the same time, it's a very, it doesn't have any melanocorticoid activity at all, zero melanocorticoid activity. So that is why for replacement purposes, when you have adrenal insufficiency, we prefer giving hydrocortisone. But whenever you wanted an anti-inflammatory effect, we go for glucocorticoid activity because we need this glucocorticoid action for the anti-inflammatory effect of the steroid. So that's why whenever you need an anti-inflammatory effect, prefer giving a prednisolone, methylprednisolone or dexamethasone. Dexamethasone is a very, very powerful steroid. That is why the current dosing protocol tells like you have to give 6 milligram IV OD. But methylprednisolone for that matters. You have to give it a higher dose of 80 milligram standard, or even you can go up to 125 milligram OD because by conversion, methylprednisolone is a little bit, like less powerful glucocorticoid compared to dexamethasone. But still, if you give it a correct dose, they are also very good glucocorticoids. Yes, it's a recovery trial. I don't want to use the trial-based, the names of the trials to avoid the confusions, but this is what we have been trying. But what it has been time tested and proven is the fact that this methylprednisolone has superior lung penetration. I don't know whether it will be useful for any final year student over here because it's a totally practice-based information. So this is having a superior lung penetration. That is why still in our hospital we stick on to methylprednisolone. Anyways, that's all right. So could be steroid induced. If it is steroid induced, patient should ideally not have a fever, just an elevated total count, and that's something definitely steroid related and nothing to be treated. And we don't want to do anything for this patient. But clearly this patient is having a fever, so I'll not be thinking just it's a steroid induced manifestation of elevated total count. So it cannot be taken lightly. So probably secondary infection. It could be any secondary infection, all right. So it could be starting from your pneumonia. It could be starting from your UTI, urinary tract infection, because patient was not actually catheterized. As the patient was catheterized in the ICU, can early steroid prescription prevent severe disease? No. Answer is right now no, because COVID is a very, very early disease which we can't predict how it's going to behave in the future. But right now, answer is no. Then why do we use dexamethasone, betamethasone for lung maturity in preterm neonates? So that's because there is something called placental penetration. There's something called a placental penetration. Among all the steroids, dexamethasone is the only one that has a good placental penetration. Hydrocortisone, very, very poor placental penetration. Prednisolone, methylprednisolone has inferior placental penetration compared to that of the dexamethasone. Dexamethasone and betamethasone are the ones that have superior placental penetration. The reason for their, remember dexamethasone is not only a very powerful steroid but a very long-acting steroid as well. What the hell? It's not only a powerful steroid, but it's a dexamethasone is not only a powerful steroid, it's a very long-acting steroid. For that matter, it acts for approximately 36 to 54 hours. This is the half-life of dexamethasone. The reason for their long-acting placental penetration and superior efficacy all are due to their very much reduced CBG binding. That's called cortisol binding globulin. So dexamethasone binds very, very poorly to cortisol binding globulin. So that is the reason for their increased half-life. So that is also the same reason, since they do not have much of cortisol binding globulin, they have a good placental penetration as well. The free dexamethasone levels will be a little bit good and they have a good placental penetration. So that's why around we use dexamethasone, betamethasone for lung maturity as far as fetus is concerned. Alright. So secondary infection, it could be, let's come back to our case, it could be a Secondary infection, all right, which could be anything, right from your probably your bacterial infection to fungal infection to your urinary tract infection, could be anything. So very commonly in hospital patients we encounter this COTI, that is catheter-associated urinary tract infection, but this patient was not catheterized, so it's very unlikely to have a COTI. And somebody has mentioned, Arun has mentioned about ventilator's pneumonia. So it cannot be ventilator's pneumonia, not possible, because VAP will happen in people who are likely to have endotracheal intubation, and post endotracheal intubation after 48 hours. After 48 hours, you will be after 48 hours if you get a pneumonia. This is what we refer to as a ventilator-associated pneumonia. This patient, for that matters, he was just on non-invasive ventilation, and he was not endotracheally intubated. So it will not be a VAP. Clear? It will not be a VAP. Patient was not endotracheally intubated and unlikely to be a VAP. So it's not a VAP. Definitely it's not a VAP. So I'm not going to think about a VAP. So steroids will suppress the immune system, so the patient is getting bad. It's a doubt. Actually, no. So it's, I think, I don't know the name. I'll just call as Dr. Rose. Dr. Rose has asked steroids will suppress the immune system, so the patient is getting bad. Is it? No, actually. There are a series of acute phase reactants. Yeah, Anushka Tomar, correct. Hospital acute pneumonia could be an hospital acute pneumonia. Hospital acute pneumonia definition is very simple. Any patient who's getting a pneumonia after 48 hours of hospital admission. That's what we called as a hospital acute pneumonia, previously called as a nosocomial pneumonia. Anyways, we have a group of positive acute phase reactants are there. In that, ferritin is a very important positive acute phase reactant. Interleukin 6 is a very important positive acute phase reactant, and a lot of others are there. CRP is a positive acute phase reactant. Many positive acute phase reactants are there. But for that matters, this IL-6 is one of the very, very important positive acute phase reactants, which was unregulated in its nature. In the sense, it is, you can imagine this like a rogue, like cytokine. So it's not something which will be regulated properly, and its levels can go dramatically high in certain conditions like viral infections and superintelligence. Especially in case of viral pneumonia, it's been proved that this IL-6 behaves very rogue, and it can behave very badly, and it can go up, multifold than more than any other inflammatory markers. So that is why initially there was supposed to be a correlation between IL-6 and ferritin. They thought to be there was a correlation between IL-6 and ferritin, but currently we don't have any such correlation between ferritin and IL-6. People who are having 3000 ferritin are having IL-6 values of only 50. People who are having just 250 to 300 ferritin are having IL-6 in the range of thousands. So there was clearly not a very good correlation between IL-6 and ferritin. Initially it was thought that all these things are positive acute phase reactants, so all these things must rise together. But right now it's been very clear that this IL-6 is not going to relate with other acute phase reactants because it's unregulated and likely to be rogue, and the genetic reasons behind this significant elevation of IL-6 compared to other acute phase reactants are yet to be elucidated. So we don't know very clearly, so why does this happen? But anyways, this IL-6 is the reason for lung injury, and that's what we define as a cytokine storm. And to prevent any further lung injury and ongoing lung injury, we are trying to give tocilizumab. So that is the ideal and rationale behind giving a tocilizumab. And who's asking? Ajay is asking, is there any Cvp line insertion? No, this patient is not having any Cvp line insertion. And in our hospital, we have a good practice that we don't insert a central venous line unless and until it's absolutely necessary. Usual indications for central venous line is whenever the patient is not having the peripheral line at all for resuscitation. And second, probably if you want a very, very high dose of inotropic or vasopressor agents, because high dose inotropes and vasopressors, if you're giving in the peripheral line, the limb might go for gangrene because of severe vasoconstriction in the peripheral areas. So for that conditions, we use a central line, but apart from that, we don't use central lines unnecessarily. So why Ajay is asking that question? Because he was suspecting CLABSI. What do you mean by CLABSI? It's a central line associated bloodstream infection. But anyways, this patient was not having a CVP. So unlikely to be a class C. Can fever be because we stopped medicines? That's a good question. So fever is there because we stopped the medicines. Actually, it's unlikely. The fever because we stopped the medicines because the patient actually recovered. Patient was actually recovering here. So we can put a differential diagnosis though. So the first differential diagnosis is steroid induced, which was no. Second is secondary infection, which was yet to be determined. And third one is probably, as you said, recurrent infection. That's what he's telling. Recurrent or relapse, whatever. So that's unlikely in this patient because we have clearly seen that the patient has started recovering and his fever settled by day 6, day 7 itself. And there was a new increase in the total count. So this increase in total count is unlikely to happen in the COVID. So usually in COVID, we see a setting of low counts only, maybe around 4,000 to 6,000 is what we see. But apart from that, we don't have that much of increased count. So it's unlikely to be a recurrent COVID infection in this case because, and again, recurrent infections has not been proven. In the world right now, maybe in Korea there are 2-3 cases which are genuinely proven to be recurrent, but we don't know. Other areas only it's just a problem in the swab techniques or something that might come as initially negative and then it can come as positive. We don't take it as a positive swab. Anyways, that's not a sign of a recurrent infection. Difference between glucocorticoid and mineralocorticoid, that's too much of a theory. So in general, I will tell glucocorticoids are anti-inflammatory. Mineralocorticoids are salt retaining. So they retain sodium in the body. So this is the basic difference between a glucocorticoid and a mineralocorticoid. So this is the maximum I can tell as of now. Thank you so much, Subhash. Anyways, so you have recurrent infections here. So that is again eliminated. So we have ruled out VAP. It's not unlikely to be a VAP. It's not a CLABSI because the patient didn't have a central line. It's not a COTI. It's not a it's not a catheter-associated urinary tract infection as well. So our only differential diagnosis, the first thing to be ruled out is secondary infection. This is the most important, and that's what the guidelines also are telling. Please take my point. Any patient after day 14, if they have fever, it's mandatory right now as a guideline to rule out secondary infection. This is very, very important. This patient started developing by day 14. Maybe incidentally, I'm not telling exactly started on day 14, but incidentally he developed fever on day 14 also. And you have to rule out secondary infection. Why not on day 10? Why not on day 11? Remember, fever as far as COVID is concerned, it can start from, it can be up to 14 days. So, we have seen fevers which can actually, why it's not working? They can have fevers which can actually be there up to 12 days. Up to 12 days, you might get a fever in case of a COVID patient. So this is what we have been seeing. Just presence of fever does not tell you the severity, but anyways, persistent fever may be related to severity. We have an ongoing trial that is happening right now. But anyways, fever is variable. It can range from less than 1 day to up to 12 to 13 days. This is what we have been experiencing right now. So there are many things are there. Persistent fever, vaguely correlates with severity. Vaguely correlates with severity. Suppose if the patient is having fever for more than 5 days, more than 5 days of fever, usually you have to watch carefully because this patient might deteriorate. Suppose if the patient has not desaturated, why this bloody thing happens? Okay, so if the patient has not desaturated by day 10, still is having a fever. Still this patient is suffering from a fever. So in this setting, mostly it is likely to be a post-necrotic fever or post-inflammatory fever. There is something called a post-inflammatory fever. So that is what the likely entity is. So by day 10, somebody has not desaturated, still spiking. Actually, it is a sign of reassurance. So usually it won't be a sign of severity. Usually it will be a sign of post-inflammatory fever. And many of the times, fever in COVID settles better with indomethacin and NSAIDs. So usage of NSAIDs and indomethacin is currently indicated. Usually, I start with a dose of 25 milligram TDS, or you can use a SR tablet, 75 milligram 2 times a day. So you can follow any doses, doesn't matter. But NSAIDs in general, particularly indomethacin, brufen, are likely to be more efficacious in reducing the fever in terms of COVID-19 patients. So, but anyways, any patient with persistent fever for more than 5 days, watch them very carefully because they vaguely correlate with severity and they might become bad. Suppose if the patient has not desaturated by day 10, still they are having fever. The current evidence says that it's likely to be a post-inflammatory fever, and this patient is unlikely to develop any complications. So nothing to worry. So fever in COVID patient can generally be treated with NSAIDs, which give a very good response. So indomethacin is very good right now for treating the fever related to COVID. So if the patient is having fever related complaints and patient is not having any fever that is settling down, you can try indomethacin. Works in almost like 50 to 70% of the cases, it introducing the fever. Favipiravir, cures COVID. Absolutely wrong. There is currently no cure for COVID. So you have to be very clear in that fact, and you have to accept that we don't have cure for COVID. Very important. And is there any role for glycine? No, only experimental. And we have been having a suggestion on the pathogenesis, but no. So right now we don't have any sufficient evidence for that as well. Only we are suspecting, but we don't have any concrete evidence. And again, no cure right now is available for COVID. Favipiravir is being currently approved for only moderate cases, so mild, moderate, and severe. I don't know, government of India has approved for both mild and moderate cases, but I don't think that's right. Guidelines clearly tell in mild cases it's not useful, severe cases also it's not useful. Only for moderate cases, it is marginally beneficial in terms of hospital stay. They reduce the hospital stay by approximately 1 to 2 days, and they can reduce the fever and cough. That is, the symptoms of COVID can be reduced by approximately 2 to 3 days. So this is the benefit of using favipiravir. Suppose if we want to know the dose, we give 1800 milligram into 2 doses on day 1, 12 hours apart, then followed by 800 milligram BD up to 14 days. So we are going to give for 14 days till day 14. So this is a standard dose of favipiravir right now, but anyways, it's not beneficial for mild or severe cases. HCQ is in only mild. Again, the same answer for everything. There is no role for any drugs right now. As of now, we don't have any much role for any of the drugs except for steroids and tocilizumab, which has been greatly proven to reduce the inflammation related to COVID, but we don't have any cure for COVID right now. A lot of drugs have evidence for reducing the viral shedding like remdesivir, but still we don't have evidence to cure COVID right now. Cool. But anyways, so we took a CT. That's what I've been telling from the beginning. I've shown you I've told you the question in the beginning itself, told you that this patient was taken a CT. So what is the CT finding? So this is a repeat CT image. And can anyone see anything here? This was the patient CT. I'm showing you the CT. Can anyone see anything here? Somebody can comment. Till that I'll be answering. Plasma therapy have a role? Yes. Plasma therapy, yes, we have a role. And convalescent plasma has been proven to be beneficial. Anirudh is asking symptoms such as anosmia, loss of taste could be related to glycine depletion. Does explain high death rates in elderly who have lower glycine reserves. Anirudh, I'd like you to tell one important point here. That's why glycine has been implicated in the pathogenesis of COVID, and that's been thought to be due to, causing the loss of taste and anosmia in COVID. But trust me, patients who are having anosmia and loss of taste contribute to approximately 30 to 40% of the COVID patients. And do trust me, majority of these patients who have this anosmia and loss of taste tends to do extremely well. And that's why I'm telling you, I don't know about the glycine depletion and related pathophysiology, but clinically speaking, patients are having anosmia and loss of taste. According to our observations right now, they tend to do really, really well. And they don't have any even moderate disease. Many of these patients end up with mild or asymptomatic disease. That's what the clinical observation we are having right now. Okay, anyone see anything here? Anyone wants to test anything here? Anyone wants to tell anything here? I don't know whether it is streaming or not. Is there any issues in the streaming? Yes, I'm back online. So somebody is telling interstitial pneumonia, remdesivir, favipiravir difference. There's no much. I'll come back to that. Ground glass opacity, crazy pavement, ground glass opacity, crazy pavement, air crescent sign, usual interstitial pneumonia pattern, Aspergillosis, bronchiectasis, prominent bronchoalveolar markings, Aspergillosis. Fine. So Ashish is very particular on Aspergillosis. I think he has seen the CT already. Probably, I'm not very sure about that. But yes, the idea is correct. So this patient is having an Aspergillosis. This is the area I wanted to look at and I want to diagnose here. So what you're seeing here is the typical sign of an invasive Aspergillosis. This is what we refer to as something called an air crescent sign. So more than air crescent sign, this is what we call it as a telltale evidence of your invasive Aspergillosis forms. So why invasive Aspergillosis is quite common in this particular invasive in this patient, because remember we have given methylprednisolone to this guy. So let me put the we are given methylprednisolone to this guy, all right, and more than methylprednisolone we have used tocilizumab also. Remember the fact that it's not an ABPA, it's not allergic bronchopulmonary aspergillosis. I'll come back to that. So tocilizumab, methylprednisolone, all these things we have given. Okay, sorry for the interruption. Still introducing Oreo to you all. See? Okay, I think she came inside somehow. Okay, we have given methylprednisolone and tocilizumab. So which means we have dramatically depleted the interleukin 6 and at the same time we have given a steroid dose also. So this itself poses a risk of fungal infection, because one of the important things about this steroid is the fact that they can predispose to fungal infections, and especially this IL-6 depletion has been associated with fungal infections in the literature as well. So we have to be a bit careful about developing this fungal infection in these guys. So you can see a lot of areas like this. So let me tell you why you get this sign in the first place. Anyways, this is a patient with an invasive pulmonary aspergillosis, telltale without a doubt. 100% it's an invasive pulmonary aspergillosis, no doubt. But even before taking a CT scan, we did serum beta D glucan assay. Remember, the serum beta D glucan is emerging as a very good test for that matter. Any contraindications for drug usage in COVID patient, especially diabetic hypertension? No, right now there is no evidence for that. You can continue the drugs whatever you want. There is no evidence to tell that these drugs are going to give adverse prognostic benefits. Anyway, so serum beta D glucan. Serum beta D glucan can be positive in 3 conditions. One is candidemia, and probably with aspergillosis, with a specific type of aspergillosis called invasive pulmonary aspergillosis, not all types of aspergillosis. And second one, we have another type of disease called PCP, pneumocystis cat pneumonia. These are the 3 areas where you can get positive or elevated serum beta D glucan. But the point here is, some people are telling about galactomannan assays. Yes, galactomannan can be used, but the problem is galactomannan is much less sensitive compared to that of serum galactomannan is much less sensitive, much less specific compared to that of beta D glucan. So remember, galactomannan is actually a fungal element, and it can be positive, it can be falsely positive even after beta-lactam injections, because beta-lactam are drugs nothing but penicillins. Majority of these penicillin drugs are actually got from a fungus called penicillium, and like this penicillium is a fungus, and they also can contain galactomannan, and these beta-lactam drugs itself can be contaminated with this cell wall of the fungus, that is a galactomannan. So that is the reason why after giving penicillin drugs, this patient can develop a false positive galactomannan. That's why we don't use galactomannan right now. It's serum beta D glucan is relatively more specific. So one of these 3 conditions can be there, but you have to be very clear what is the condition, because for aspergillosis, gold standard is we give voriconazole. In ICU setting, for candidemia, we are going to give caspofungin or anidilafungin. In general, I prefer using a caspofungin. Whereas this pneumocystis carinii pneumonia is concerned, we are going to give cotrimoxazole, TMP-SMX, trimethylene sulfonamide. So whenever serum beta D glucan is positive, we have to rule out all these 3 things, because all these 3 things can become positive as far as your serum beta D glucan is concerned. But here I'm having a clear-cut sign. I'm having a telltale sign of this is a very classical sign of a invasive pulmonary aspergillosis. It's not an allergic pulmonary aspergillosis, it's just an invasive pulmonary aspergillosis. Actually, it's quite dangerous to have an invasive pulmonary aspergillosis, and it's not easy to get rid of this disease as well. But trust me, why do you get that sign? So first of all, whenever you have an immunocompromised state, in the sense probably a patient could be on long-term steroids, high-dose steroids, or drugs like tocilizumab, or patients receiving a cancer chemotherapy, which is causing very much decline in the neutrophil count. So this is what we refer to as a febrile neutropenia. So the patient is having a febrile neutropenia due to some chemotherapy. It could be methotrexate as well. So whenever you are having some problems like this, the lung may show diffuse consolidation. So at this point of time, it's very difficult to predict what is the infection. So that is the reason why we have this galactomannan beta D glucan assays and all. So at this time, what we do is, for example, whenever the patient is having severe immunocompromised state and they're coming with some fever and infection, for example, a lung infection, pneumonia, we have to start with empirical antibiotics. And this empirical antibiotic should be having a broad spectrum cover. For example, in our setting, we give a piperacillin tazobactam or a meropenem. So this is what we start with initially. Once you are given a piperacillin tazobactam or a meropenem, if still the fever does not resolve for more than 48 hours, you have to think about alternative cause. So probably you have to think about MRSA, probably. This is very true, especially if the patient has central lines, especially in the form of dialysis catheters, HD catheters. If they have this, you have to definitely think about MRSA pneumonia in this setting. So MRSA sepsis probably. So in these settings, we will be adding vancomycin depending on the renal function. If the renal function is bad, then you can prefer adding other drugs like daptomycin or linezolid. But there are some drugs which can cover MRSA. In the hospital setting, we are talking about hospital setting MRSA. In the hospital setting, your vancomycin will cover, teicoplanin will cover, then linezolid will cover, daptomycin will cover, Then quinapristine and dalfapristine will cover. This available in a brand name called Sinercid. Quinapristine dalfapristine combination and tigecycline will cover MRSA. And your fifth generation cephalosporin. Fifth generation cephalosporin, that cefpirone, can cover MRSA. So these are the drugs that generally cover hospital-acquired MRSA. But whatever may be the drug, I will always believe vancomycin is the gold standard. This is the gold standard. And vancomycin and teicoplanin are both similar. Teicoplanin having a relatively lower renotoxic effects compared to vancomycin. The only problem with vancomycin is the fact that it's a drug with narrow therapeutic index and it can cause serious nephrotoxicity. And we can't use vancomycin in patients who are having nephrotoxicity, plus if you are living in a setting where you cannot measure vancomycin trough levels frequently. If you are able to measure the vancomycin trough levels, still you can go ahead with vancomycin, no problem. But remember, irrespective of the renal function, the first dose of vancomycin can be given, that is 1 gram stat dose of vancomycin can be given if you suspect an MRSA, irrespective of your renal function, no problem. But from the second dose onwards, you have to be very careful because the renal function is very bad. Then you can't give the full dose of vancomycin. Either you follow the trough levels of vancomycin and give the drug accordingly, or you can vaguely give vancomycin once in 48 hours. That 1 gram dose in 48 hours you can give, depending on what is the renal function. If they are in HD, I tend to give 500 milligram once in 48 hours. They're not on hemodialysis, having a good urine output, I tend to give 1 gram every 48 hours. But the best thing is to assess the trough levels and then decide on the vancomycin levels. Linezolid, I generally don't like linezolid because it's a bacteriostatic drug. Unlike vancomycin and teicoplanin, they are bactericidal. Linezolid is bacteriostatic, and many trials have proven that if you give linezolid in a patient who's having a central line, how will you identify renal dysfunction and give him vancomycin? If the patient is already having renal dysfunction, that's what I believe. The patient is already having elevated serum creatinine, because many of the critical care patients will have elevated serum creatinine as a part of their sepsis and underlying infection itself. So that's what I am trying to tell. So if the patient is having central lines, giving a linezolid is actually associated with a reduced mortality. If you don't have any renal function, give vancomycin, no problem. Then you serially check the serum creatinine every alternative days. That's it. So I will give full dose vancomycin, 1 gram IV BD. That's the full dose vancomycin that I generally tend to give if the patient is not having any renal dysfunction at the time of giving vancomycin. So if you use linezolid, by talking to you, I made one grievous mistake that it increases mortality. So this is what the trial told. So that is the reason whenever the patient has central lines, especially HD catheters, and if you're suspecting MRSA pneumonia, avoid linezolid as much as possible. Being a bacteriostatic drug, and patients are having higher mortality, so we don't want to use this drug. And finally, what about this daptomycin? Daptomycin, on the other hand, it does not have good lung penetration, which means it can be inactivated by surfactant. Daptomycin is a drug that can be inactivated by surfactant. So that is the reason for pulmonary infections, we don't prefer using a daptomycin. So pneumonia patients, using a daptomycin is not a good choice. Quinapristine, dalfapristine, yes. Tigecycline, yes. Fifth generation cephalosporin, also yes. But always the gold standard is going to be vancomycin. So this is what the guidelines are telling. Suppose even after starting vancomycin, by 72 hours, even after starting vancomycin, within 24 hours, if it's an MRSA, the fever will settle. For sure, it will settle. If it's not an MRSA, definitely it will not settle. Even after 72 hours, if your fever is continuing, then you can try empirical antifungal cover. Empirical antifungal cover. The ideal choice is amphotericin B versus probably a voriconazole. When is your Unacademy full course going to start? I think I'm starting my course on July 13. I will show you after this. So voriconazole versus caspofungin. But it's really difficult to select it's difficult to select one of these drugs, and again what to give is a very tough question. So usually in our ICU we start with caspofungin. Amphotericin B is highly renotoxic, even including a liposomal amphotericin B we don't give because it can result in hypokalemia, distal RTA, so much of problems are there. And voriconazole is the best drug as far as Aspergillosis is concerned. So if you're sure that you're dealing with a case of Aspergillosis, then voriconazole is excellent drug. Caspa has very inferior activity to invasive pulmonary Aspergillosis, but still, for candidemia, caspofungin is an extremely good drug. So, but anyways, vancomycin continue or discontinue. So unless and until you are sure with your MRSA status, you continue vancomycin. So that's the idea. So you can start with empirical antifungal. If your empirical antifungal responds, then probably after that you can discontinue your vancomycin. In this case, what we did is the patient was already getting, because we have started with tocilizumab. The moment we started tocilizumab and methylprednisolone in this patient, we empirically start with, in our institution, what we do is we empirically start with some broad spectrum antibiotic. That is really a very important point, because giving tocilizumab and methylprednisolone itself poses the patient to under substantial risk of infection. So generally we start with empirical antibiotics in these guys. So in our hospital, it's our practice to start with piperacillin tazobactam empirically for all the patients for pseudomonal cover. So this patient was already on piperacillin tazobactam, but still he had a fever despite having piperacillin tazobactam cover. And this patient was not on any central line. So this patient is unlikely to have a CLABSI. This patient is unlikely to have a ventilator pneumonia. So both these things will tell that this patient is unlikely to have a MRSA as well. So as a routine pattern, after this, since the patient still had a fever, we sent for serum beta-D glucan, which came out to be positive, and we started with caspofungin as usual because the serum beta-D glucan was positive. And along with serum beta-D glucan, we did a CT chest also. This was an empirical caspofungin we started with, and patient was done with the CT chest as well. So CT chest was very clear that I was seeing that R crescent sign, which is clearly suggestive of a invasive pulmonary aspergillosis. So what we did is we converted this caspofungin, we stopped this, and we converted to voriconazole because there was a clear evidence of invasive aspergillosis. We started with voriconazole. Once we started with voriconazole, the patient's fever resolved and the patient improved in saturation, and all the parameters started declining, even including the total count started declining after voriconazole. The standard dose what we give is initially we give an IV dose, then followed by an oral dose of 200 milligram BD, oral dose of 200 milligram BD, and the dosage for invasive aspergillosis has to be at least for 3 to 6 months. We give for a considerably longer duration of 3 to 6 months minimum. In extremes of scenarios, depending on the response, I have given voriconazole even for almost 11 to 12 months itself in some patients. And it again depends on the follow-up CT and how much the lung is responding. So that's what it is. But you have to give for a longer period of voriconazole. That is really, really important. So especially if you are thinking, if you are having a invasive aspergillosis. So now coming to Nilashish Datta was asking about how do you get the R crescent sign in case of a aspergillosis. Let me tell you. That's why I told you, initially at the time of pneumonia, you cannot really tell whether the patient is having aspergillosis or not. You're going to get a uniform consolidation, and that's what this patient also had. Let us go back to the CT and see what this patient had. So remember, there are very little ground glass, to be honest. There are ground glass. I'm not telling little. There are ground glasses, but majority of the areas are actually consolidated. Remember, these are the areas of consolidation. So when you see full-blown whitish structures like this, these are areas of consolidation. So this is an area of consolidation. And many people who seeing the first might see this as a cavity. Yes, you are right. It's a form of a cavity only. But why do you develop that kind of a sign, invasive pulmonary aspergillosis? The reason is very simple. As I told you initially, when you take the lung, so you're going to only develop a consolidation. So a lot of areas will be showing consolidation. And this consolidation might be due to invasion of aspergillosis. This consolidation may be due to invasion of aspergillosis. But what happens is, this invasion of aspergillosis happens during the time of immunosuppressed state. We know that very well. But once the immunosuppressed state improves, which means in this case we have stopped the steroid, we have stopped tocilizumab, and the patient's immunosuppression has improved. So, on the other hand, for example, if the patient is receiving a cancer chemotherapy, you have stopped the cancer chemotherapy, and you have given some drugs like filgrastim that is going to boost the neutrophil count in case of a febrile neutropenia. Anyways, once the immunosuppression improves in these patients, the counts will start improving. Once the total count starts improving, once the immunosuppression gets better, and once the immunity wakes up, it sees a whole lot of Aspergillus that is invading the lungs. So what generally happens is that now the neutrophil starts attacking this Aspergillus in the lung, and they start producing areas of necrosis. They'll be producing areas of necrosis within the lung. So which means if you take in the cut section, for example, if you see this is the area of consolidation, and now what really happens is this area is full of Aspergillus and an area of consolidation, and this neutrophil start attacking this lung and they start causing necrotic areas. So that area of necrosis will be later on, because lung is something that's filled with air, and that area will be filled with air, and that is why you get that crescent sign. So that is why you see an air crescent sign there. So background area of consolidation, and you'll be seeing a area of necrosis. That really happens because of improvement in the immunity, which means what I'm trying to tell is the fact that initially you will not be able to find out this air crescent sign in the first place. Only when the immunity improves, only when the patient has improvement in the immunity and immunosuppression is improved, then only the neutrophils start attacking that area, then only you will be starting to get this air crescent sign. So what you are seeing essentially here is the area that is attacked by the neutrophil. So what you are seeing exactly in this particular slice is the fact that you are seeing a background area of consolidation. So this whitish area is a consolidation, and this crescent shape is due to necrosis created by the neutrophils. That is due to improvement in the immunity. So this patient had improvement in the immunity because we have stopped the steroids and the tocilizumab drug. So that is the reason. So that is the reason why this air crescent sign happened. So I think Nilashis, you will be clear about that now. No. That's why I told you I have ruled out that. So if you go back to our previous slide, I have ruled out that it's not due to steroid-induced increase in TC. I told it could be a probable steroid-induced increase in TC, but I think I've ruled out. Just hold on. It could be a steroid-induced, but I clearly told you, but that is not the case because we have ruled out here. So that's not due to steroid. I have ruled out here. It's not possible, steroid-induced, because we are not thinking about steroid-induced increase in TC here. Anyways, so this is the reason why we got this invasive pulmonary aspergillosis here. So ideally, the treatment of this invasive pulmonary aspergillosis is voriconazole. That's the gold standard. There is no other drug that is much better than voriconazole in a setting of invasive aspergillosis. Anyways, aspergillosis in a nutshell, if you see, there are three types. One is called an allergic bronchopulmonary aspergillosis. Then we have something called semi-invasive aspergillosis. That is what we refer to as a chronic pulmonary aspergillosis. Then we have an invasive pulmonary aspergillosis. What determines whether to get an APP or a chronic pulmonary aspergillosis or an invasive pulmonary aspergillosis is the fact that the immunity is a major player here. If the patients are hypersensitive to Aspergillus antigens, they develop this allergic bronchopulmonary aspergillosis, and they are generally not invasive, non-invasive forms. And if the patients are hypersensitive to Aspergillus antigens, they are going to develop this non-invasive form of allergic bronchopulmonary aspergillosis. Very commonly happens in the setting of bronchial asthma, cystic fibrosis. Since cystic fibrosis is not common in our country, it happens in the setting of bronchial asthma, where the patient's serum Ig will be elevated significantly to levels more than 1000, because this is a type 1 hypersensitivity reaction. So serum Ig will be elevated. Patients will have eosinophils, and patients will be having typical mucus production in the form of mucus plugs that comes out, and the patient might complain a brown colored sputum, rusty sputum, because of the aspergillus, brown black sputum, because the aspergillus that is coming out of the lungs in the form of a sputum. So that is how it is, and the treatment is usually with steroids and itraconazole. And clues for diagnosing this allergic bronchopulmonary aspergillosis. Clues for diagnosing this allergic bronchopulmonary aspergillosis is the fact that you're going to have a refractory bronchial asthma, or uncontrolled bronchial asthma. That is the clue for diagnosing this allergic bronchopulmonary aspergillosis. Any patient coming with uncontrolled bronchial asthma, which was previously controlled, one of the differential diagnoses is allergic bronchopulmonary aspergillosis. So in the chest X-ray, you will be seeing some radiological signs like finger in glove appearance. Doesn't matter, anyways. So this is what you're going to see, anyways. Chronic pulmonary aspergillosis has a lot of forms. Here the immunity likely to be normal. So even though the immunity is variable, normal or mild suppression, the immunity will be there. Probably. That's why you get a chronic pulmonary aspergillosis. It could be right from a non-invasive form that is called aspergilloma. Aspergilloma is like an old TB cavity, where aspergillus will come and attach to it. Just as an opportunistic pathogen, it will be non-invasive and it will not have any fever or any invasiveness into the blood. But the patients can present with massive hemoptysis. Because of rupture of certain vessels, they can come with massive hemoptysis. That's the only problem. Apart from that, it doesn't give any trouble at all. And this also gives rise to a air crescent sign, because you will be seeing air like a crescent here, because this is an aspergilloma fungal ball. This is what we refer to as a fungal ball. And you have a air crescent over here. So this is also, another form of air crescent, but this form of air crescent is called by a different name, called as monod sign. So this is called by a different name called as monod sign. So this is what happens in an aspergilloma. This is the first form of chronic pulmonary aspergillosis, and you have a second form of chronic pulmonary aspergillosis where you have invasion into the lung parenchyma, but not into the blood, but no angio invasion. Angio invasion will not be there. It is not an angio-invasive form of aspergillus, which means blood will not show any invasion of aspergillus, which means you will be having only a negative galactomannan and a negative beta-D-glucan. You will not be having any positive testing, because only in the blood, if your aspergillus is there, then only you will get a galactomannan or beta-D-glucan positivity. So it's a form of invasive, but there is no angio-invasion. It's a moderately severe form of aspergillus. There are two types are there in this. One is called a chronic cavitatory pulmonary aspergillosis. Then we have a chronic cavitatory necrotizing aspergillosis, each of which has its discussion on its own. So we have to have a separate discussion on its own. And once again, the treatment is going to be itraconazole. Itraconazole, especially if you're having a CCPA or a CCNA forms. Chronic cavitatory pulmonary aspergillosis or chronic cavitatory necrotizing aspergillosis, you are going to give itraconazole only. As far as this aspergilloma is concerned, no treatment is necessary. In the sense like no antifungal therapy is necessary, and you might be needing a surgery. Surgical intervention can be done for aspergilloma, but medical intervention is what you do for chronic cavitatory pulmonary aspergillosis and chronic cavitatory necrotizing aspergillosis. Clear? So let me come back to that. Okay, chronic cavitatory pulmonary aspergillosis and chronic cavitatory necrotizing aspergillosis. All right. Then we have a third form, is the most severe form, that's an invasive pulmonary aspergillosis, where actually it happens in severe immunocompromised state. The patient will be in severe immunosuppression. There in allergic bronchopulmonary, patient was having more immunity, hypersensitive. In chronic pulmonary aspergillosis, patient was having normal immunity to little bit low immunity, whereas in invasive pulmonary aspergillosis, patient is having a severe immunosuppression, typically in the setting of chemotherapy, febrile neutropenia, bone marrow suppression, and stem cell transplant, that is bone marrow transplant, after bone marrow transplant, or any transplant for that matters, but generally a bone marrow transplant, that is where you see such a low count, or patients on high dose immunosuppression, like high dose steroids like methylprednisolone, pulse dose, tocilizumab. So these are the risk factors for developing this invasive pulmonary aspergillosis. And these patients tend to have an angio-invasive aspergillosis, which means beta-D-glucan and galactomannan tends to be positive here, and they will be developing angio-invasive form of aspergillosis, which means they are going to invade the blood itself. And it's very difficult to confirm. In CT, you might see that air crescent sign, but that will happen only after recovery of the immunity. Till that, you might not get that sign. But anyway, somehow the treatment gold standard is voriconazole, IV followed by oral voriconazole. This is the treatment of choice, and this is the gold standard as far as invasive pulmonary aspergillosis is concerned. It's a very, very difficult diagnosis to make. Suppose if you are not able to make out this air crescent sign, then in this setting, if you still have a diagnostic confusion and if you're strongly thinking about aspergillosis, there is no other option. You have to do a bronchoalveolar lavage. Suppose if you're having a bronchoalveolar lavage, you have to stain with PAS or you have to stain with gomori methenamine silver. For how many days you have to give variconos? I told you already you have to give 3 to 6 months. I have given even for 11 months depending on the radiological resolution, but the guidelines generally suggest in a variable period of 3 to 6 months. That's what the duration of voriconazole is. I mean, that's what I've been answering. And you can stain with PAS or gomori methenamine silver stain, where you'll be seeing aspergillus with this kind of typical septate hyphae, which will be branching and it will be dichotomously branching, and it will be having branches at 45 degrees. This is very important difference from mucar. The degree is very, very important differential from mucormycosis. Yes, that's it. So this is what you'll be seeing. Once you see this kind of a fungus, which is septate, having a septate hyphae, having dichotomous branching at 45 degree. Neha Khatun, why don't you attend Dr. Rakesh Nair sir lectures? Maybe you'll learn some medicine. Thank you so much. I don't know that much medicine. Whatever medicine I know, Neha, I am teaching it. Maybe I'll try attending his lecture. Maybe you can also try learning some manners to how to message in the YouTube. Thank you very much for your suggestion. I'll try doing that. Okay, so I think we have finished today's session. So let us finish off. So today is a case of an invasive pulmonary aspergillosis. That must be the case for the day. Anyway, so if you have any doubts, you can ask. Otherwise, we can sign it off because it's already 11:40. Okay, I mean, Neha is already accepting that she's illiterate, and I think she wanted me to comment on something. I think, yeah, thank you, Rachit. Thank you. I think Neha wants me to comment something. Whatever you want me to comment, you can tell separately. Okay, so we have finished the discussions. The role of aspergilloma without symptoms to surgery is the treatment, sir. Yes, we better do surgery because at some point of time they tend to develop this hemoptysis. That's the idea. Role of CT in the management of COVID. See, remember, CT is helpful in the first time, not CT is helpful for the first time. CT is generally helpful for the first time, but whether it has any serial CTs have a role or not, we have no idea. We have no idea whether serial CTs have a role. We have absolutely no idea for that. But first, CT is generally helpful because CT is the sensitive investigation as of now. Not. Thank you, Neha. Thank you so much for your suggestion. So, first investigation. I mean, it's a very good first investigation because it's highly sensitive. So sensitivity of CT is considered to be approximately around 97%. That's the sensitivity of CT, to be honest. But specificity is a bit poor, but still it's coming up with a good specificity as well, because we have some CORADS classification. I think if you have any confusions, you can go and verify this CORADS classification. So this CORADS classification will tell you how to tell the specificity of CT with regards to the COVID-19. So that also is coming up right now. So anyway, sensitivity is extremely good. Remember, the PCR sensitivity for COVID is only 70 to 80%. It's very good till day 5. Till day 5 of fever and symptom onset, it's extremely good, maximum sensitivity. But beyond this day 5, especially when the patient goes to ICU, its sensitivity dramatically drops. In ICU, you can get a negative COVID-19 also. That's fine. So that's not an issue. So CT is having a very good role as far as the sensitivity is concerned. CT is having a very good role. it can be a very good first investigation compared to the RT-PCR itself. Then what are the role of vitamin C? So remember vitamin C, then zinc, all this are supposed to be, reducing the viral load, and this is what has been thought. But again, the answer is questionable. We don't know really, so what's going to happen? So zinc, vitamin C, all are questionable. So I mean, we use it routinely right now for all the patients, but what is the real role? We don't really know. So what's going to happen? So right now you use a lot of drugs. So of which methylprednisolone and tocilizumab, or probably a dexamethasone or dexamethasone. So these are the only things that are okay as far as the preventing cytokine storm is concerned. So only for preventing cytokine storm, these are beneficial. But apart from that, role in mild or asymptomatic cases is unknown. We have to answer a lot of questions. We have to answer this question. We don't know yet, but for severe cases, so when do we start with methylprednisolone and dexamethasone? Methylprednisolone and dexamethasone can be started at the first instance of desaturation. Desaturation in the sense, in COVID, we take a saturation of less than 94%. So whenever you have a saturation of less than 94% at the first instance of desaturation itself, it's better to start with methylprednisolone or dexamethasone. Whatever you want, you can start, doesn't matter. Tocilizumab, in a patient who is having cytokine storm, you can start with tocilizumab. Cytokine storm is defined as elevated IL-6. We don't know what is the elevation. Again, what is the range of IL-6 elevation? We take it as cytokine storm. We don't know. Plus, at the same time, if the patient is having severe lung injury with severe lung involvement, so in those settings, you can start with tocilizumab. So these are the indications. But anyways, the role in mild to asymptomatic cases, we really don't know. So that's one problem with methylprednisolone and tocilizumab. Second, we have this antiviral drugs, multivitamins, zinc, vitamin C. All these things, probably they can reduce the viral shedding, even including hydroxychloroquine and chloroquine. They reduce the viral shedding. At the same time, they can reduce the viral entry, but we don't know what is the exact idea. Cool. So fine. So that's fine. That's all right. So these are the current role of these drugs. And apart from that, there is low molecular heparin that has been coming up. Low molecular heparin that's been coming up in the recent times. So this is based on an Italian study on autopsy. In Spain, Italy, France, they did an autopsy in which they have found out that almost 70 to 80% of the patients who died of COVID had venous thrombus, that is in the pulmonary arteries. There have been a pulmonary artery thrombus, and they thought like this pulmonary artery thrombus could be the reason for the sudden death in many of these patients. So that is the reason why we are starting with empirical low molecular weight heparin. We are starting with full dose of empirical low molecular weight heparin. For what patients to start, again we don't know. We generally currently starting for moderate to severe cases, and again mild to asymptomatic cases, we don't have any role for low molecular weight heparin. For all moderate to severe cases, we start with empirical low molecular weight heparin. But there are some guidelines that tell like ferritin levels more than 100. You can start with empirical low dose low molecular heparin, but I don't believe in these guidelines. I think that's wrong. That I don't think is the correct one. But anyway, in full dose in the sense we give 1 milligram per kilogram subcutaneous BD. That's a standard dose of low molecular heparin. Full dose low molecular heparin. Therapeutic dose, that is what we give. How many days? Typically for 5 to 10 days again, or typically till recovery. So that's what, whichever is late you can give, either 5 to 10 days or till recovery. Recovery means the patient should not have fever. Patient should have a good saturation with low level of oxygen, like 2 to 6 liters per hour, 2 to 6 liters per minute. So this is the definition of a recovery as of now. So you can give low molecular heparin for 5 to 10 days or till recovery. So these are the drugs that are currently available. But right now the most important armory is the methylprednisolone, tocilizumab, and low molecular heparin, and probably the most important being the oxygen. That's it. And prone oxygenation has been coming up in a very good way now, because proning has a lot of mechanisms. I've described in one of my YouTube videos itself how proning works. You can go back and see my YouTube video, which is published under my channel. So anyways, prone oxygenation is having a good outcome as far as oxygenation is concerned, but we don't know about the long-term outcome. Normal ferritin reference range is what Subhita is asking. It is 10 to 100 if it's a female, and 20 to 200 if it's a male. But generally up to 100 or 200 you can take it as normal. That's a normal ferritin range. That's it. Asymptomatic case of COVID is there anyway. Actually, only if they test you can find out. Otherwise, it's not possible. That is why we do something called a contact tracing. Contacts also can be tested. So only then you can find out these asymptomatic cases. Otherwise, it's impossible to find out asymptomatic cases until they have some symptoms. I think we have covered in detail about, these are some of the treatment modality, because treatment itself needs a separate discussion. We need a one full YouTube discussion or one full special class discussion as far as treatment is concerned. So much are there, but none of which is actually proven right now. None of the antiviral drugs are proven to be curing the COVID. So anyway, concise management of chart of COVID, I will try to do it, because I have created a separate algorithm for that in my hospital. But anyways, we'll do that later on. So I'll tell you this. I'm going to take the concise batch course, which starts from July 13th for people who are asking again. So this is my Telegram group, Dr. Dilip's MMS. So you can type in it's a public group, so you can type in the search box and you can find out the group and you can join if you want. And usually my time will be 10 and after 10. So that will be my time, because currently I'm too busy on the COVID duties. So, it's being really bad right now. So 10 o'clock is what the time I'm going to come. And if you are going to like my class, you can use my code, that is Dr. Dilip 10, and you can use this code to avail 10% discount. Yes, and yeah. So this thing can be seen, and I think this will tell you how to subscribe to the Unacademy Plus subscription, and these are the upcoming free classes on NEET PG. And there is a foundation batch course also which is going on, which is going to start on 18th June. Clear. Thank you so much. Thank you everyone for your patient understanding, and I think actually after a point of time I thought thank you, Neha. Thank you for making the class very entertaining, and thank you very much. And I think I expect you for the next session as well, because you are really funny. Thank you very much. Good night. See you.